Hello and welcome back to the IJA Podcast. We're rolling on and picking up from where my colleague Dr. Amrita has left off with part 1 of the author's views for October issue in an interview with Dr. Pankaj Kundra. Today we take over from there for the part 2 of the episode. As always, we have with us Professor Dr. Rakesh Garg, the esteemed editor-in-chief of IJA. Welcome, sir. Joining us, we have the experts in the field of anesthesiology. Firstly, I would like to introduce Dr. Bidkar Prasanna, who is a professor and head of neuroanesthesia at JIPMER and the author of one of the two articles in focus today. His article, The Comparison of a Novel Anterior Out-of-Plane Approach with Standard In-Plane Approach in Ultrasound-Guided Supraclavicular Subclavian Vein Cannulation, won the best paper at ISACON South Zone 2024. So welcome, sir. Welcome, and thank you for taking out the time to be with us today.
Thank you, Gautam, and very happy to be here.
Thank you, sir. Next, I would like to introduce Dr. Neeru Sahni, who's a additional professor in the Department of Anesthesia and Critical Care in PGIME at Chandigarh. She's also the author of the second article that we'll be discussing today, that is Understanding the Number Needed to Treat, or NNT, a practical guide for anesthesia and critical care physicians. So I welcome you, ma'am, and thank you so much for taking out the time.
Thank you, Dr. Gautam, and thank you, Rakesh sir, for giving me this opportunity. Thank you.
Thank you so much. I think your contribution is always advancing the research and improves the clinical care of our patients. So thank you both of you for coming together and sharing your research into the journal as well as in today's podcast.
Before we begin, Dr. Rakesh sir, like if I would ask you for our long-term listeners, if there's anything new or upcoming with the IJA that you would like to highlight and tell us, that would be great. Thank you.
IJA always comes out with the researchers' hard work, their efforts for a couple of months, at times years also, by bringing good research which is being published into the Indian Journal of Anaesthesia. So thanks to all the authors and researchers who are contributing in the advancement of medical science, specifically in the field of anesthesiology, perioperative medicine, critical care, and pain medicine. As far as the IJA is concerned, we'll be coming for a theme issue in this January, which is almost ready and will be released very soon. This is more focused on the regional anesthesia. And Dr. Gautam, you are aware of, you are also enthusiast of facial plane block. So this will be more dedicated towards the facial plane blocks. Now we have a good number of blocks in the armamentarium of facial plane blocks. And to my surprise, every week there is an addition of one. I do not know where the list will end for facial plane blocks, but it is always good to see that those facial plane blocks, which started a couple of years back, is getting more advanced, more focused, and the anatomical and sonological interpretation of these facial plane blocks are getting better. So this special themed issue of January 2026, in which again we have a couple of narrative reviews, technical reviews, meta-analysis, as well as the research articles, will provide a good insight into the facial plane blocks, which has become one of the important armamentarium of regional analgesia techniques nowadays. So keep looking into the IJA, and very soon the themed issue will be released very soon.
Okay. Thank you so much, sir. I think that is very, very exciting that there's more of regional anesthesia work coming out in the IJA. So that keeps me on my toes as well, always wanting to learn new regional anesthesia techniques. Thank you, sir. So let's just move right along to the first article in focus. So Dr. Prasanna, I have gone through your wonderful paper, and as you may be the case with many of the listeners as well, who have gone through it, they would have realized the aha moment that you had when you developed this novel technique. So I would just like to ask you, what was the frustration or the challenge that made you think there has to be a better way to do this?
So actually, because we do have the MD course and the DM neuroanesthesia course, and as a part of the training, we keep on experimenting on different things. So as my entire career is focused on neuroanesthesia. So most of the cases are major surgeries. So all the cases we put central line and arterial lines, they are the bread and butter for us. So as you know that when we put a IJV, we face a unique problem when the head is rotated. That starts kinking. The central line starts kinking and becomes non-visible in the intraoperative period. So most of the time we tend to tilt towards putting the subclavian lines. So when we talk of subclavian, that infraclavicular subclavian is the one most commonly preferred. But as we know that it is a blind procedure and ultrasound guided subclavian vein cannulation, it has its own challenges. So this made us think that why not to go a supraclavicular. Lot of times it has been described supraclavicular subclavian either a blind or ultrasound guided. So I started experimenting with this, then found that some of traditional explanations are not very satisfactory. Like it is a difficult for the 3D orientation of the residents to orient the needle in the in plane and get into that. So that started, this is the one which started inventing that whether I can go out of plane and then get it. That was the idea behind that when we started it.
Yes, sir. I think the way that you've done it, the numbers really jump out. So what I saw from the article as well, that your first pass success rate was 95%.
Yes.
Versus 77% with a traditional approach. So in practical terms, if you're doing about 100 central lines a month, so an 18% point difference means a lot for the patients. What do you say,
Absolutely,
sir? Like
absolutely.
this,
It's a
this
huge,
would
huge.
really change things. Yeah.
Yeah, absolutely. It is a huge jump from what we get, particularly in terms of supraclavicular subclavian, whether it is in plane or out of plane. That's a huge jump in the success rate. And also the uniqueness of the way we do it. So as you could have read in the article, so there are, when we talk of out of plane approach, so you go basically out of plane to the ultrasound beam. So when we put this probe in the supraclavicular area like this, we have two options to go, either from the posterior to the probe or the anterior to the probe. So when you go to the posterior to the probe, if you are not going in parallel to the probe, you are likely that you will miss the needle and you are likely to counter the pleura and the subclavian artery. The subclavian artery just behind there. So that's why I came with the idea that let us go anterior to the it so that we have the better control. So we started going from the space between the ultrasound probe and the clavicle, a narrow space there. Through that you have the better control and the direction also. So part of the needle also you'll be see nicely when actually the needle enters below the ultrasound probe like in plane. It's not actual in plane. What we are piercing is the out of plane. But when it actually enters the distal part of subclavian vein or the right brachiocephalic vein, you can see actually the some length of the needle. That makes it more interesting. And the angulation part, which I think you must have seen through the article. Classical to the out of plane, we are not going from the midpoint of the ultrasound probe, a slightly lateral to the midpoint and angulating medially. If you see the classical description of supraclavicular subplane in the blind technique, that is how it was taught to us, that you target the opposite nipple, so go in that angle. So here also we have tried to go, because if you see the images what we have provided in our article also, there is a pleura down like this. So if you go parallel to the pleura, then you have a very less risk of puncturing the pleura, because you are going parallel to the pleura into the right brachiocephalic vein through the junction of the subclavian vein and the brachiocephalic vein. That makes its success more, and also the subclavian artery becomes posterior. So very less risk of puncturing the subclavian artery also. That's a uniqueness of this technique. So we described and I practiced quite a lot on a lot of patients. Then I thought, after doing hundreds of cases, why not to validate with a study? And that was the reason we studied this, and we presented our research work in the South Zone conference in the ERCAD last year and got a best paper award also for.
Yes, sir. That moves us, so that's really wonderful what you've told us, which moves us on to the safety story also, what I was saying. You had only there were 5 arterial punctures in the traditional group versus only 1 in your technique. So that's a potentially serious complication. This is, so like you mentioned, so this is how with your technique, the approach reduces the risk also for an arterial puncture.
Absolutely, because when we...
About the learning curve reality, sir. Yeah.
Yeah, absolutely. What I was telling you, when we
Sorry,
start
sir. Yeah, please.
looking at this technique, we start from the IJB, start moving the probe downwards, and when we reach the clavicle, we start angulating it. So first angulation, a minimal angulation of 10-20 degrees, you will see the subclavian artery. You angulate little bit more, you start seeing the subclavian vein and the brachiocephalic vein in the angulation. So when you go from anterior, you have no chance that you will prick that subclavian artery, because it has already been left behind, unless you go to interior. And the length we are measuring, it's hardly 1 or 1.2 centimeters from the skin insertion. So it makes much more successful And since we are going to the parallel to the pleura, that much still more safer technique that we are very less likely that will puncture the pleura also. But when you go traditionally in plane technique, you have to think three-dimensionally. The resident or the faculty who is doing it has to think in a three-dimensional way. The needle has to go medially also, along the probe also. So then if the full length of needle is not seen, then he may likely go posteriorly a little bit and hit the artery. And if he goes deeper, then he will end up into the pleura. So that's the uniqueness of our technique. I feel everybody
Yes,
should practice it.
yes, sir. So there are instances when it doesn't work. So I saw that you had achieved a 98% success, but there were a few cases where you had to abandon the procedure. So what were the patient characteristics or anatomical variations that made this technique uniquely challenging in those patients?
No, because this part of the area is known for variations. So sometimes you will not get the proper window. When you do not get the proper window to show it, better to avoid it or go to the alternative technique. That's it. So 98% means almost in every patient you are getting a good window. One or two is likely to happen. So because no, this one can be successful. If you see our classical video laryngoscope studies also, still we have not been able to achieve a 90% success so consistently with any available video laryngoscope. So I feel it's a very reliable technique and reliable anatomy is there. One or two patients you may have to do it. Sometimes what happens when we have used either a IJV or a subclavian vein cannulation previously and we want to redo it. Sometimes that time may not be that anatomy may get altered because of long-term cannulations. That may happen. Otherwise, fairly in most of the patients you are going to get it.
So this also looks to be the future of central access, if you ask me. So you won the best paper at ISACON South Zone. And what has been the response from the other centers, sir? Where do you see ultrasound-guided techniques heading in the next few years?
So absolutely daily new things are evolving, particularly in terms of regional blocks and all. I do very less, but in terms of I am a very enthusiast about use of ultrasound. My most of the ultrasound works around the brain, most of transcranial Doppler and the brain ultrasound. Plus, I keep on experimenting with these type of things. What I can do in my area of field. Very less of regional anesthesia I do. I see ultrasound will come everywhere. Now, if you see without the ultrasound, even a neurosurgeon is not ready to touch the patient. The moment bone is removed, he will put the ultrasound to look at the tumor. That's how it is going to. So more and more uses will come, more and more new approaches will come. Hopefully, we will also come up with more new techniques and publish in our the best journal IJA. So let us see how it will go. And I think future is exciting with the use of ultrasound. Absolutely, because you are seeing what you are doing. That's it.
So thank you very much, sir, for your insights. And I'm sure those who have gone through your article can benefit a lot from this conversation, or those who listen to this can go back to the article and then gain a lot from what has happened. So,
Absolutely.
Rakesh, sir, would you like to, if you have any questions for Professor Prasanna?
I've gone through the article. I think this one is one of the landmark technique. And when we talk about the central venous cannulations, though we have moved from conventional, traditional technique, landmark-based technique to the ultrasound do have its limitation, and which has been highlighted in this. I think we need more robust, big study to compare various, you can say, the scanning techniques for finding the dynamic venous cannulations, which can be successful. And people are moving towards long-term indwelling catheters. So that becomes a big issue because the silicone catheters, which are more friable, more softer, they may not negotiate these structures very well as compared to the PVC-based double lumen or triple lumen catheters. So these techniques needs further study for these type of catheters, maybe like Hickman catheter, indwelling catheters. I'm sure these techniques will bring more success. And this becomes more important when we talk about patients who are in coagulopathy. So when we say coagulopathy, we have to be absolutely sure that we are not puncturing the arterial portion, number one. Number two, we should also be sure that the first attempt, which is the best attempt, is the successful attempt. And we can explore these type of scanning tools, scanning techniques actually, which Dr. Prasanna and his team has come up. I'm sure this will be beneficial when it's extrapolated to these difficult scenarios also. So thank you so much, Professor Prasanna Bidkar and your team for contributing landmark paper. And I'm sure it will be having a lot of clinical utility in coming times. Thank you so much. And back to Dr. Gautam Reddy, our host for the day.
Thank you, sir. Thank you. So let's move on to the second article for today. So Dr. Neeru, I have gone through your work as well. And since this topic, I would say a lot of us find it to be scientifically more challenging to understand in the right way. And I would like to start with the basics. Could you just explain to our listeners what a number treated to actually means, and why did you feel this topic needed a dedicated practical guide right now in the present moment?
Yes, so Dr. Gautam, it's number needed to treat is just another metrics. It's a metric in clinical research, and it just represents the number of patients who need a specific intervention as compared to a control group to achieve that one additional benefit effect that we are looking for. So it is a direct measurement of absolute effectiveness of that intervention. So all the research findings we have, it helps us translate those research findings into something meaningful for making clinical decisions in our practice. So once it's basically a plain language conveying the message of the research findings to the people who are actually going to, apply the results of a research. So we actually analyzed systematically the randomized control trials, especially the ones with the binary outcome. Those were published in the year 2024 in IJA. And our analysis revealed that there is significant underreporting of number needed to treat. So hence we felt that there's a need to discuss a practical guide, how to calculate number needed to treat and what are the practical implications and various variations which we mentioned in our follow-up commentary.
I think, yeah, that's what I noticed as well in the introduction that you mentioned, that the p-values and confidence interval, they dominate statistical reporting currently. So what's the problem with that, and how does NNT fill a gap those traditional metrics miss?
Yes, so to consider the effects of intervention to be significant only based on p-value less than 0.05, it is actually too simplistic. And you see the terms significant itself loses its semantic meaning when clinically significant treatment effects are ignored as soon as this p-value is not less than 0.05 or it becomes equal to 0.05. So it's kind of, it's like numbers going here and there and the clinical significance of the research getting missed. So suppose you have a hard outcome which you are studying, like mortality. Now, if you have a p-value of 0.053, it is not significant. You have a p-value of 0.049, it is significant. So how logical it is to, have just one number declare the significance and not significant. And the clinical significance is just basically lost when we only look at the p-value. Mentioning confidence interval is definitely a very good idea. But what happens is that people usually mention confidence interval and just look that the null is included in that confidence interval. The width of the confidence interval is not properly reported. And what we mainly need is that we have to report the confidence interval of between group differences, like the treatment effects. So what NNT does is it offers a concrete practical impact of a treatment comparison. Now, it can assist the clinicians in benefiting whether a treatment is going to be helpful or it can even be harmful. So you have number needed to treat, number needed to harm. So it is basically when you adopt metrics like NNT or NNH, which is number needed to harm, the researchers can provide clinicians knowledge about how to practically apply these things, and they can ultimately help improve patient care. It is also easily conveyable to policymakers, like, this thing done, this is a number needed to treat. So it can be conveyed to policymakers also for appropriate resource utilization.
Yes, ma'am. I think you had to highlight these. You had also mentioned quite a few interesting examples. So one of them was a really good comparison, I would say, like two scenarios where you had identical relative risk reductions, one being 37.5%, but dramatically different NNTs. So that's like 7 versus 67. So this seems like it could lead to very different clinical decisions. So can you elaborate on when a treatment might look impressive in relative terms, but less so in absolute terms?
So if you remember the example, the relative risk reduction is similar in both the examples, 37.5. But what is different is the control event rate. the experimental event rate, and the absolute risk reduction. So what happens is once you have a higher baseline risk of a certain thing in the population, a lower NNT can be derived. And a higher NNT comes when you have a low risk population. So the control event rate, whether the population is high risk or whether the population is low risk for that event, that is actually going to interfere the number needed to treat. So we should remember that your absolute risk reduction, it scales directly with the baseline risk of that population. So the relative risk only is not going to, we are not going to interpret things only based on the relative risk reduction. We have to understand the control event rate and the absolute risk reduction. And that is how so basically, if you don't have the baseline risk reduction risk idea in a certain population, it will become difficult to interpret number needed to treat.
Many clinicians also seem to confuse the risk and odds. Can you just help our listeners understand this distinction using a simple example? And why does it matter whether we report odds ratio versus relative risk?
Technically, if you see the definitions, the risk ratio is the relative risk is the ratio of probability of an event occurring in exposed group versus an unexposed group. And odds is the ratio of odds of an event in exposed group to the odds in the unexposed group. So I'll just give a very basic examples with some oral calculations possible. So if we give a drug and 40% of the patients who receive the drug get headache and 60 do not out of 100. In the unexposed group, where we give the same placebo to 100 patients, only 20 develop the headache and 80 people do not. So 40 in the drug group and 20 in the placebo group develop headache. So when you calculate risk in the exposed group, that is 40%, and risk in the unexposed group, that is 20%. So it is very easy to calculate that this is, a doubled. So patients who will receive this tablet will, in place of placebo, there will be a double risk of headache. So, but when you calculate odds ratio, so now odds in the exposed group will be 40 people developing 40 out of 40 divided by 60. So the odds in the exposed risk group will be 0.67 because 40 are developing headache and 60 are not developing. And odds in the unexposed group, 20 will be developing and 80 will not. So 20 by 80. So that will come out to be 0.25. Now, when you calculate odds ratio for this, it comes out to be 2.67. So basically what happens that odds ratio and relative risk are not at all similar, especially when you have a common outcome where it is occurring in 20% population, 40%. So your odds ratio, it exaggerates the true effect. So relative risk is just the double, which is intuitive and looks logical also. But when you calculate odds ratio, it is like over exaggerating the true effect. So it is very important to see what kind of study you are applying, which of these. So basically for the studies which are prospective studies, we should calculate the relative risk, and we should use odds ratio typically in case control studies. So this, we have to understand the odds ratio of 2 does not mean that the relative risk will also be 2. You need a proper calculation, so it will come out to be different.
Thank you, ma'am. That was a wonderful example. I think it made it much more clear for all of us to understand that. You also mentioned there were several pitfalls. So what's the most common mistake you see clinicians making when they try to interpret or calculate NNT? Any memorable examples from your experience?
So basically, number needed to treat and number needed to harm are two different things. So when you calculate number needed to treat, it's like 1 divided by the control event rate minus experimental event rate. But when you calculate number needed to harm, it is 1 divided by experimental event rate minus control. So basically, it is the direction. If you're not interpreting the correct direction, then it is going to be difficult. Similarly, when you have NNTs from various studies and you're trying to pool the data of the studies, we cannot pick up NNTs and then, pool the data. We have to get the absolute risk reductions from each study and then calculate the overall NNT. So it is not like we will get the NNTs and take an average or something like that. So these are the mistakes which can commonly occur. Especially in critical care, a lot of studies you see the primary outcome they take as composite outcome. So the composite outcome could be discharge, number of discharge days or mortality. So ideally for precision of your result reporting, one should calculate the composite outcome NNT also and individually report NNT for all the parameters that we have included in the composite outcome. So these are the things we need to follow when we talk about number needed to treat.
I remember
Yeah.
how we took up, because the Indian Journal of Anaesthesia for a long time was helping the authors to go a step ahead of p-value. And Madam had just mentioned about its importance, because p is nothing of having some, you can say, clinical interpretation. It's just that things are happening by chance, that is, or not happening by chance. So in that context, Indian Journal of Anaesthesia has come up with series of statistical tool and its uses for our authors, readers, so that we can interpret our hard work much better. Because you have everything, you just have to understand an addition of a tool and interpret it appropriately. She just has given a very good example of P.049 versus 5051 or something like this, where just a small change, and actually p-value is not saying that a group is better than the other or worse than that. So we have to proceed something different, and that's why we have been critically appraising our articles also, just to make the author's work a little more, you can say, interpretable by using this statistical tool. And Dr. Neeru Sahni and the team has done that marvelous work to give certain values in addition to what the authors has reported. So it is basically a critical appraisal of the IJA itself. But then, yes, it has bring up more understanding of the published articles into IJA, and I'm sure people will be able to understand better. And maybe Dr. Neeru was saying something.
I was saying that a lot of hard work goes into having an idea for research. So, formulating a clinically relevant research question, then devising the methodology, then doing the hard work of data collection, getting all approvals. So now if we in the end can interpret our results so that, they can be usable for the clinicians and policymakers, I mean, it will all be too great.
That's true. We understand that being a part of certain guidelines and policy at times, and similarly, senior persons like you would also be part of those. Sometimes when we are making policy or a guidelines, we need to understand these values. And as we have been in IJA, sometimes we have to get the data and do it. The event rate, we have to do it. And then we say that, yes, just to incorporate this extra drug or extra strategy, if I put it in a simple way, when we say number needed to treat, it will be just in a simple language. If I can express, Madam has already explained it, that NNT basically expresses that how many patients we need to receive a treatment to help one extra person for a particular intervention. So, for example, if I say that if I have a new drug and it is being used for postoperative nausea, vomiting, and if this new drug prevents PU in out of, say, 100 patients, the NNT would be 100. So this means sometimes if you think that if I need to avoid one PUNV, whatever the p-value has come up, I have to treat 100 patients. And is it financially viable? If it is something very harmful with increased mortality, probably it would be. But if it is a benign issues, such as, say, just a nauseating sense, so probably treating 100 patients to avoid one nausea may not be financially or maybe infrastructurally viable. So that's why even these values needs to be interpreted. Same is for NNT also, for NNH also we need to understand. So probably we'll say, if you get something where you say the NNT is 1, this means it's a wonderful drug, right? Whatever the p-value is, because every patient is getting benefited of your intervention. If you say NNT1, it will be immediately policymakers will think, okay, why not to include it, whatever it is, because it is helping all patients. So this is how we need to interpret. Sometimes we are looking for various aspects. And that is what through IJA, as a part of, I could say, CME or educational material, various authors, including Neeru Madam and others, do comes up with those ideas where we are emphasized the importance of RRs, ORs, and NT and NH. Then some time back, we had the understanding of the confidence interval and its interpretation. Similarly, we have emphasized the importance of meta-analysis. There was a full issue where it gives a more robust evidence. So IJA always believes that this type of understanding for the novice researchers, I understand the seasoned researchers do well, but then we have to encourage the upcoming researchers so that they are our future leaders, actually, future researchers. So just to support them, we are coming up, and this article was in line to that particular aspect to understand more. And probably in near future, we will be continuing our expression of using these advanced statistics to little more higher version, and which is, again, IJA emphasizes, it's not the detailed discussion. It's basically the detailed, you can say, the interpretation of data, and let people interpret according to your situation becomes important.
Thank you, sir. Thank you. I think IJ in that way has been wonderful for young clinicians and researchers who are coming along to understand these techniques and also how to interpret the vast number of articles coming out through journals. So we're able to make better decisions clinically and going about. Thank you so much, sir. Madam, coming back to you, we wanted to talk about coming to number needed to harm, as you had mentioned. How do clinicians balance out number needed to treat against number needed to harm when making clinical treatment decisions? Is there a framework that you would recommend for this?
So we determine the number needed to treat for a positive outcome and number needed to harm for any adverse event that could happen. And we need to understand the ideal balance. So an ideal intervention would be which has a very low NNT, as sirs told, like a single digit NNT, and a high NNH, like the number needed to harm is very high. So this would mean that there is a strong benefit of this intervention, but a very low risk of harm because of this intervention. So in a way, we can actually interpret LHH, which is likelihood of being helped or harmed. So if you divide NH and NH, number needed to harm, by number needed to treat, and this number is greater than 1, it would suggest that treatment is much more likely to help the patients than bring any harm. So we can interpret both NNT and NNH and then make a balance, looking at if number needed to treat is favoring that this is a strongly beneficial thing to do for a patient with very minimal risk of harm.
Just listening to you and knowing how good NNT can be used in making these types of decisions going forward clinically, what is your advice on reporting NNT in papers? Like, should it always be included alongside relative measures, or are there situations where it's not appropriate, where you shouldn't be using NNT?
See, I believe that one should learn how to construct the 2x2 tables. We gave it in detail in the commentary we published. We should be able to calculate the event rates and then interpret absolute risk and relative measures. So, but one thing is that NNT may not be reportable if your absolute risk reduction is 0, because it is a inverse of absolute risk reduction. And when you have some data like time to event data, in that data, Kaplan-Meier approach must be used to calculate NNT. We can't apply 2x2 approach. So those are two different things. And if you have a methodological issue in a manuscript, like the blinding has not been done properly, then whatever NNT you calculate, it may be inaccurate. And then that inaccurate NNT does not hold any meaning for any clinician or any policymaker. So we have to have a robust methodology also to be, for that NNT to be reliable.
Thank you, ma'am. Yeah, so I think just from all the questions and discussion we had today with you, made a lot of the topic to be very digestible. So I would just like to ask you if you could get every anesthesia and critical care clinician to remember one thing from this guide, what would it be?
We wrote this commentary, we would urge that everybody doing research or trying to publish the report or results of their research, they should pause and analyze that how the results of these interventions they are reporting, they are going to help change the clinical practice or be meaningful for any clinical decision making. Because the research is basically done to guide clinical management. It is not like it should remain solely in publications and has no applicability when it comes to bedside patient care.
Thank you so much. Yeah. And where do you see this going, ma'am? Do you think journals and researchers will increasingly embrace reporting NNT as a standard practice? What needs to happen to make that shift?
I think it's the responsibility of the editor-in-chief, the other editors, and the whole team of so many reviewers we have. Their effort goes a long way in improving the result reporting of the manuscripts which we receive for reviews and which are then received and approved for publication. So their effort actually goes a long way. They can help improve the manuscript by asking the specific questions to the author, like in your revised manuscript, submit these data along with the already submitted p-values and confidence intervals. And slowly the authors will also realize that this is probably more easily understandable and useful for application. And I think the effort of the whole team is needed here.
Thank you so much, ma'am. Thank you so much for explaining all that you have done and having this wonderful conversation with us today. And to be honest, like when the October issue had come out and then you go through all the articles that came out, it doesn't really pop out that, an NNT article being that is the first thing that you would go to. But then when you look at it, it really becomes an important tool for young researchers and somebody who reads clinical papers also, regularly, that it is very important that this has come about. So thank you so much for your time, ma'am.
Thank you so much, Dr. Gautam, for having me here. Thank you so
Thank
much.
you so much. Thank you. And with that, I would just like to ask Professor Dr. Rakesh Garg if there's anything he would like to add or before we close out for today.
Thank you so much, Dr. Neeru Sahni, for your active and informative contribution to the growth of research and academics and its contribution towards the Journal of Anaesthesia. And in fact, I should say thank you, Dr. Gautam Reddy, also for always hosting the podcast in such a nice manner and to extract the information from the gray cells of the expert researchers that comes out here so that everybody of us are benefited with regards to our clinical care. So special thanks to the whole of my IJA podcast team who has been working so hard, sometimes behind the screen, mostly behind the screen actually. So thanks to each one of you from the IJA podcast team on behalf of the whole editorial board of IJA, and keep listening, remain curious and read IJA. Back to Dr. Gautam Reddy for the concluding remarks. Over to you.
Thank you so much, sir. Thank you. So with that, I would like to thank both the authors for joining us today, Dr. Neeru and Dr. Prasanna. And we've hoped to see you again on the podcast. And it was lovely having you and listening to your experience and expert opinions. Thank you to all the listeners for tuning in. And until next time, stay curious and stay hungry. Signing off. Thank you.
Thank you. Good evening.